Good afternoon, and thank you for joining us. I'm Nicholas Gessner, and I am a research fellow at the National Institutes of Health, as well as the program coordinator for the Migraine Science Collaborative. For those of you who are new to our community, the Migraine Science Collaborative is a subsidiary of the Association of Migraine Disorders, or AMD. AMD is a nonprofit organization that strives to expand the understanding of migraine through research, education, and awareness. Under AMD's research pillar, we have developed the Migraine Science Collaborative, which is a resource hub and communication platform designed to facilitate networking for researchers and medical professionals. Today, I have the pleasure to learn more about care gaps and recommendations in vestibular migraine, as identified during an expert panel summit hosted by the Association of Migraine Disorders and published in Frontiers in Neurology. Joining me are two individuals who served on the expert panel, Dr. Monica Mallampalli and Dr. Habib Rizk. Dr. Monica Mallampalli is a senior scientific advisor at the Association of Migraine Disorders, where she has led efforts to grow their research program since 2019. She considers herself as a fierce women's health advocate, and for over a decade has been working to advance women's health from research to policy. She is a trained biomedical scientist with a Ph.D. in human genetics from the University of Utah. She also has a master's in science degree in biochemistry from Osmania University, which is located in India. After obtaining her Ph.D., Dr. Mallampalli went on to do a 4-year postdoctoral fellowship at the Johns Hopkins School of Medicine in the Department of Cell Biology. After completing her fellowship, Dr. Mallampalli joined the National Institute of Diabetes and Digestive and Kidney Disorders at the National Institutes of Health as a research fellow. It was here at the NIH that Dr. Mallampalli decided to leave bench research to work as a health policy analyst at the National Institutes of Mental Health. Soon after, Dr. Mallampalli realized that she wanted to work for an advocacy organization and joined the Society for Women's Health Research. During the 7 years she was at the Society for Women's Health Research, Dr. Mallampalli was the chief architect and subject matter expert on several programs related to women's health and sex-based biology. In 2017, she left the Society for Women's Health Research and founded the Institute for Women's Health Strategies, with the goal of partnering with other organizations to reduce knowledge gaps and disparities in women's health from research to policy. Besides the Association of Migraine Disorders, Dr. Mallampalli also serves as a senior scientific advisor for healthywomen.org, where she brought national focus to the topic of women and chronic pain, and serves as the chair of the Chronic Pain Advisory Council. Currently, Dr. Mallampalli also volunteers on several nonprofit boards. You can find her on LinkedIn, Facebook, and Twitter. She also has her own website launching soon. Dr. Habib G. Rizk is an associate professor of otolaryngology, head and neck surgery at the Medical University of South Carolina in Charleston, South Carolina. He is the director of the Vestibular program at the Medical University of South Carolina, one of a few nationwide multidisciplinary programs. Dr. Rizk served on the board of directors of the American Balance Society, is a member of the Equilibrium Committee of the American Academy of Otolaryngology and Head and Neck Surgery, as well as a representative of the Academy in a joint task force with the American Academy of Neurology to investigate improvement measures in neurotology. He is a member of the Berenice Society and on the board of directors of the Vestibular Disorders Association. He is also the chair of the Research Ethics Committee in the South Carolina Clinic and Translational Research Ethics Institute. Dr. Rizk is also involved in hearing-related and dizziness-related research and has over 40 articles published. He is currently conducting clinical trials assessing the efficacy of an SNRI in the treatment of Meniere's disease, a trial funded by the American Hearing Research Foundation and the Cures Within Reach Foundation. As a reminder, Dr. Mallampalli and Dr. Rizk are just two of many talented individuals who collaborated on this effort. For a full list of co-authors, please visit our LinkedIn page. We also plan to address audience questions at the end of the hour, so please enter them in the chat as you see fit. Welcome, Dr. Mallampalli and Dr. Rizk.
Thank you, Nick.
Let's get right into it. So Dr. Mallampalli, firstly, I want to say that in 2019, the Association of Migraine Disorders hosted their first expert panel to discuss care gaps in migraine. What triggered AMD to tackle vestibular migraine next?
Thanks, Nick. Thanks for the question. Yes, so in 2019, when I joined AMD, we decided to host a roundtable discussion to actually just understand the state of migraine research. The interesting part of that roundtable was we were able to bring basic researchers and clinicians together and have a conversation about what were the gaps, and not just care gaps, what were the gaps in research, and how do we sort of overcome some of those gaps. And that paper we also published, again, a whole bunch of recommendations that we felt that the migraine field should address. There was a little bit of time spent during that roundtable also discussing vestibular migraine, which was very fascinating, but we didn't get much into it. And the reason we did bring it up was because one of the co-founders, Dr. Michael Tuxedo, co-founders of Association of Migraine Disorders, have been the authority on vestibular migraine area. So that was an interest to him. And also Dr. Gardley, who's the other co-founder and the president of AMD, again, was very interested in this topic. So it's always been on our mind. And I think just last year presented that opportunity for us to delve deeper into this topic and address it. And then finally, again, the third point I do want to make is the connection between the migraine and vestibular migraine, which we've always, sort of skirted around and talked about it, but never really addressed it. So this meeting also gave us that opportunity to have a discussion around.
Yeah, I'm really interested in the intersection between vestibular migraine and migraine in general, but I'm firstly looking to Dr. Rizk to answer, what is vestibular migraine?
So that is the question, isn't it? I mean, vestibular migraine is one of the many manifestations of a migraine disorder. It's more recently recognized, and it's still underdiagnosed. As currently, the definition of vestibular migraine, according to the Berenice Society and the ICHD-3 criteria, says that these are patients who have vestibular symptoms associated with a migraine headache or a migraine equivalent, that being either a visual aura, a photophobia, and/or phonophobia. These are patients who usually have a past or present history of migraine. And again, I'm stressing the word migraine disorder rather than migraine headache, because this is where the whole confusion stems. When you talk to somebody about migraine, immediately our minds go to a migraine headache, but migraine is much more than just a headache. And vestibular migraine is one of its many manifestations.
Sure. I guess then, what differentiates vestibular migraine from migraine disorder?
So the presence of vestibular symptoms, which are a sensation of displacement in space, that could be vertigo, could be less well-defined dizziness, associated with other migraine symptoms. And to differentiate vestibular migraine from a migraine headache, if you survey patients with migraine headaches, a large proportion of them will describe that they have dizziness, but dizziness is on the background, and the headache is the most disabling complaint. If you flip the coin, vestibular migraines usually present to the provider because of their dizziness, and the headaches or the other migraine manifestations are in the background, which leads to diluting. It's not like one single specialty that sees vestibular migraine. They could end up at the neurologist's office. They could end up, and that's also very frequently so, they could end up in the ENT office.
I just want to add to what Habib just said. I think it's not about what distinguishes two. What we try to say in this paper too is there's significant overlap of these symptoms. So it's just the disorder, but also view it as a spectrum of all these symptoms, overlapping symptoms. And I think that's what we try to say here. We don't have that evidence yet, but again, that's how, if we start to look at all these disorders that connect to migraine disease, and I think you start to see all these symptoms sort of overlap, and definitely a ripe area for further research and to understand how these overlap and connect with one another.
Thank you. Dr. Rizk, how is vestibular migraine diagnosed? Who is it diagnosed by? And where should patients seek diagnosis if they experience dizziness symptoms?
Currently, the only way to diagnose a vestibular migraine is clinical. It's based on clinical history and clinical patterns of symptoms. So again, the Berenice Society lists the following criteria. You have to have at least 5 episodes of vestibular symptoms defined as a sense of displacement in space, vertigo associated with at least 2 of the following 3 symptoms: a migraine, a headache of a migraine quality, photophobia and or phonophobia, visual aura. And they have to have a current or past history of a migraine headache, and they have to have no other diagnoses that better explains their symptoms. Again, this is one of the main care gaps, is the absence of an objective test, biological or radiological, to confirm the diagnosis. But then when you see enough of those patients, the pattern of symptoms is fairly typical. That being said, who is it diagnosed by? And I kind of alluded to it a little bit earlier. Those are patients who are going to seek care. Either, it starts at the primary care's office, of course, but they may end up at the neurologist's office. They may end up at the ENT office. They may end up in the emergency room. And that's why it's so important to increase awareness of the diagnosis, because multiple specialties intersect in the care of those individuals.
Thank you. And as a follow-up to that, do clinicians treat vestibular migraine in the same ways that they might treat the common migraine disorder? And is there a cure for vestibular migraine currently?
So the treatment overlaps with the treatment of the migraine headaches. And as in migraine headaches, apart from the anti-CGRP modalities that were more recently approved by the FDA, most of the medications we use for migraine headaches were off-label for the longest time. These are antidepressants, or like nortriptyline, venlafaxine, seizure meds like topiramate, antihypertensive like verapamil or beta blockers that are used for treatment of migraine headaches, and we use them also for the treatment of vestibular migraine. Lifestyle modifications are primordial in those patients as well, and insisting on dietary recommendations and restrictions, healthy exercise are all part of what we do for migraine headaches. We also implement in vestibular migraines. And we can talk about this a little bit later. The overlap between Meniere's disease and vestibular migraine can be would require hours on its own to discuss, but being mindful and cognizant of the potential overlap with an inner ear disorder is important in the treatment and how we approach vestibular migraine as well.
Thank you. And Dr. Rizk, you just alluded a bit to lifestyle. Dr. Mallampalli, I'm wondering if there's a typical vestibular migraine patient in terms of age or sex or lifestyle.
We did mention that in the paper, seems to be more common in women. I think 2 to 3 times more common in women, and at least that's what the clinicians and the experts at our meeting did say, that those are the patients that they see. And again, women who are midlife women, typically, in perimenopause, that's when they start to exhibit the symptoms of dizziness. So definitely it's more common in women. Again, we don't have, I think we just need more data again to really, capture that. But we did try to bring it up. And there's a hormonal connection that seems to be there. Again, like I said, it's during the perimenopausal stage and the menopause. So we do need to understand what that connection is. And just to, again, for our audience, migraine 2 is very typically, it's more common, at least 70% more common in women compared to men. So it's not a surprise to see sort of vestibular migraine being more common. And it seems to be in patients who chronically had migraine, and then the vestibular migraine symptoms or the dizziness symptoms start to show up later. So definitely there's some connection there.
Sure. Dr. Rizk, how does vestibular migraine affect everyday life in your experience working with patients?
It can present in a variety of ways. There are the mild forms where patients are more frustrated with their symptoms rather than disabled. These are the patients who have infrequent attacks. And usually we manage those patients conservatively when they get a better understanding of what's happening, and we give them abortive medications to when they have an attack, not unlike what we do with a migraine headache disorder. If somebody is getting 1 or 2 headaches a year, we just treat it as it comes. However, it has a vast range of presentations that can lead to very disabling symptoms. A lot of patients present with, in addition to their underlying dizziness symptoms, they describe a brain fog, which, for lack of a better word, is alluding to a cognitive component. And those are patients who end up having problems at work, with their productivity, and they often have to call in sick, and they cannot manage their workload, and they end up on full disability if they are not managed appropriately. The other problem with vestibular migraine is that, unlike a migraine headache, it's not easily recognized when we look at the state of healthcare currently. It's often dismissed or lumped into another disorder, kind of like benign paroxysmal positional vertigo, which is treated with physical therapy, which leads actually to more symptoms. If you send a patient with a florid vestibular migraine to PT, you are making them worse, which will also lead to more disability in itself. So the disease itself can present in various ways. The way we mismanage it can make it worse. And it's very important to recognize it early and treat it appropriately.
Thank you. Dr. Mallampalli, could you give us a good idea of what the reported prevalence of vestibular migraine is?
I think the latest paper, which again wasn't to my mind, not the latest paper, but it says about 1% in the general population. But the numbers have varied over the years, and there are some numbers that say, I think, up to 7% in a dizziness clinic and 9% in a neurology clinic. But again, I think we don't have a good handle on these numbers. And as Habib pointed out, it's still underdiagnosed. So we don't clearly have the right prevalence numbers. But that's what we have right now, and that's what we mentioned in the paper. But I think the more awareness we have about the condition, we start to capture some of that information, we'll definitely have a better understanding how it impacts the general population and to what extent.
Sure, and you point to a lack of awareness about the disease as being one reason it's underdiagnosed, but are there other reasons, Dr. Rizk or Dr. Mallampalli, that you think might be leading to this underdiagnosis of VM?
So one of the reasons is that vestibular migraine can overlap symptom-wise, but also can present with other vestibular comorbidities. I talked about Meniere's disease and benign paroxysmal positional vertigo. It's very frequent for patients to have more than one vestibular diagnosis. It is well known that patients with migraines tend to have more resistant to treat benign paroxysmal positional vertigo. So patients can present to a clinician, they diagnose them with BPPV, but they miss the bigger picture, which is the presence of a vestibular migraine kind of in the background. The same thing with Meniere's disease. A lot of patients with vestibular migraine present with otologic symptoms, fullness in the ear, buzzing in the ear that gets louder because they have an underlying tinnitus that when they're feeling sick, it's kind of the perception goes up, and they are misdiagnosed as Meniere's disease. And they are treated like Meniere's disease instead of being treated for vestibular migraine. There are forms that have a combined presentation where they have episodes that are strictly Meniere's disease and others that are strictly vestibular migraine. And when I talk about this specific topic, Meniere's disease and vestibular migraine, it creates, there's a lot of passion around this. There are some people who say Meniere's disease is purely migraine, and others who say, I don't believe that vestibular migraine exists, which gets you to the realm of non-science and what people believe in. And that's partly because we don't have enough scientific or randomized controlled trials and piloted to answer those questions. And this is where the biggest care gap is, that we don't have enough data to convince the skepticals and to refrain some of the very passionate ones and find a middle ground.
And I'll also add to what Habib just said, where, there's more awareness sort of in the migraine community or the neurology community. And I think part of the reason for this meeting too is also to engage the ENT community at large and also have them understand, or bring awareness of this condition. And again, what Habib said, primary care physicians. I mean, we didn't we did try to call out that in the paper too, that primary care physicians need to also understand some of the symptomology. So I think once they get to the specialist, are able to get to the right specialist, can then get diagnosed. But there are definitely several challenges. And I think, again, alluding to what you said, raising awareness and having, the clinicians, primary care clinicians and women also understand that this is something, that they shouldn't ignore or bring it up with their doctors.
Thank you, guys. I'm wondering now if you could help me understand why clinicians and scientists don't know more about vestibular migraine and what can be done to mitigate this kind of unawareness.
One portion of this is the lack of understanding of the pathogenesis. I mean, all scientists like to know how things work, and this is one of those disorders that we still don't know a lot about. The overlap with the other pathologies is one of the main thing, and the absence of a good registry that collects data about vestibular migraine is one of the care gaps we highlighted in the paper, because we also need to know more about the multiple phenotypes of vestibular migraine. There's a lot of patients currently that present with symptoms that do not fit the criteria for vestibular migraine according to the Berenice Society. But clinicians who see vestibular disorders all the time agree that these are disorders, these are patients who have something that is very apparent to vestibular migraine, response to migraine medications and treatments. So it's basically our lack of understanding of the phenotypes, the range of clinical presentations that makes us, fall short in how to educate and raise awareness in a way. And the second point is the fact that this disorder implies seeking care into many multiple specialties. Up until recently, when I started seeing patients in clinic, the ENT residents initially were like, why are we seeing this? And then you look at the referral pattern. The most frequent referrers to an ENT or to a dizziness clinic is general ENT. Those are patients who are going to see general ENT at some point in their care. And if you don't train the ENT residents who are going to go into the community to know how to manage it, they're going to miss it. It's going to be a huge blind spot for them. And that's the work that AMD has done, and it's working with the American Academy of Otolaryngology to try to build a committee within the AAO that deals with migraine disorders in the otolaryngology patient.
And just to add to what Habib said, bringing back to AMD's focus, AMD also is focused on, understanding how migraine is connected to other systems, right? Such as what is the connection between migraine and maybe cardiovascular disease, migraine and sleep. So again, a lot of the discussions has been always in the neurology area, but we're trying to branch out and see how it connects to other specialties. And I think part of this, the discussion on vestibular migraine is sort of part of that, and an extension of those types of discussions we're having within AMD. And again, I'm trying to understand those overlaps between the two, and how it also connects to the other systems.
Thank you both. I'm wondering if you could each share which care gap or recommendation from the manuscript you feel most passionately about addressing.
Can we have more than one? I think to go first, there's two actually that I feel passionately about. One of them is the need for a good patient-reported outcome measure. My colleague Jeff Sharon at UCSF has already developed the VMPathy questionnaire. It seems like a solid questionnaire, but we need more research around it. I feel like the current questionnaires we have fall short in capturing the whole dimension of disability that those patients have. Some of them no longer have vestibular symptoms, but they still have this brain fog, that is difficult to classify. And we don't have good instruments to capture this and to capture response to treatment. And I started with that care gap because that's the main care gap that will allow us to do randomized trials about treatment efficacy, since we don't have an objective measure. And that's the second care gap I feel passionate about. is identifying an objective marker, if not to diagnose vestibular migraine straightforward, at least to differentiate it for Meniere's disease. Vestibular migraine, even if we don't have a firm number of the prevalence, is thought to be now one of the most frequent causes of dizziness walking into a tertiary dizziness clinic, even more frequent than BPPV, which is on everybody's mouth when they exit, when they come in for a consultation for a dizziness. They say, oh, it's my crystals. Well, I mean, it's as often the vestibular migraine than it is the crystals. Meniere's disease comes about at 10% of those folks. So it's very important for me to find a way to differentiate those two, especially in the early stages when the hearing loss of Meniere's disease is not fully visible and apparent.
So just like Habib, I think it's very hard to choose which is our favorite care gap, because we spent a lot of time discussing those care gaps. But I think my favorite one, the first one, is the number 5, where I made sure that we call out that this is more common in women. I mean, I've been advocating for sex differences research for so many years. So for me, at least, having that in there definitely, having that being acknowledged in the paper was very important to me. And again, I guess the care gap one, talking about how do we recognize vestibular migraine and bring more awareness to it, and which, again, Habib alluded to the need for a registry. I think that seemed like a very important way to move forward with trying to understand more about vestibular migraine.
Sure. And last question I have is, what do you feel that patients should take away from reading this paper? Should they feel hopeless because they see so many care gaps? Or if not, why not? And what can they do?
Monica, you want to tackle this?
It can come across that way, and again, but I don't want the patients to feel hopeless, because the fact is we did put this paper out. There is a lot of potential. That's why we just didn't say care gaps. We also referred to recommendations, what can be done. And I think one thing I do want to bring out is there was great energy in writing this paper and a great support. So I do want to thank all the co-authors on this, because everybody was passionate about putting this paper out and showing that there are things that we can do. So I think, again, as a women's health advocate, I want patients to be involved in this, talk about it, bring attention to this issue. We definitely need more research dollars going towards this condition. And again, understanding what is really happening with these patients. And there are treatments available. So once they're diagnosed properly, and then having the right treatment, work for them. So I don't think they should lose hope on this. Definitely there's a lot we can do, but they can also be treated and the condition can be managed. So I want this to be a positive message.
I would only add that get involved in research. That's I feel a big point when we deal with non-fatal rare disorders where we need a lot of research going, we need the patient community to contribute actively to this. And the same thing for Meniere's disease, and those are again non-fatal disorders, and we need patients to participate in whatever trial is there. So the contribution of the patient into their own health can start there by contributing to the available clinical trials. Of course, within reason, after discussing risks and benefits.
Dr. Rizk, where can patients find information about ongoing clinical trials?
Clinicaltrials.gov is a public interface. It has a public interface and it has a clinician investigator interface. They can see what's available. I can tell you right away now, there is one clinical trial ongoing at UCSF, trialing the anti-CGRP gavalizumab, the Emgality injections, and the treatment of vestibular migraine. The principal investigator is Jeffrey Sharon at UCSF. It's one of the few clinical trials currently ongoing from a treatment standpoint for vestibular migraine, and I encourage patients in that area on the West Coast to look into it.
And Nick, I would also say, to patients to engage with AMD and come look up information. We have been in conversation about how do we accomplish some of those recommendations. So there'll be more information coming from us. And then whether it's on clinical trials, whether it's on registry. And I think that that's a great way for them to follow what we're doing and stay engaged with AMD.
And I would add to this the Vestibular Disorder Association website. The VIDA is a nonprofit association, partners with AMD, partners with all clinicians who do vestibular, healthcare and research, and they are a very good resource as well.
Thank you for your time and insight. I'm wondering if the audience has any questions. I may need Heba's help to access these. Okay, I'm not sure if there are audience questions that I just can't see in the comments or not, but I did get one via private chat, and one audience member asks Dr. Mallampalli and Dr. Rizk, what is next career-wise, professional-wise for you, maybe in the realm of vestibular migraine, I'm assuming?
For me, currently, I'm focused on finishing the clinical trial we have ongoing for Meniere's disease. By the way, we are trialing an SNRI, which is a treatment for migraines in the treatment of Meniere's disease. That's where the focus of my research is vestibular migraine and Meniere's disease and how to differentiate them.
And for me at AMD, I think we're very interested in the registry concept that came up many times in conversation with the expert panel. I'll be working with Habib closely on that. We're going to explore how do we get started on that registry. And I think I feel the right way to go about this. That's the first thing you'll see from us as a follow-up to this paper.
Do you have any loose idea of when that follow-up, we can expect to see that follow-up?
In a few months. I think we've already started conversations and started a bit of work on this, but you'll hear from us soon.
Amazing. I got another question. Oh, sorry, Dr. Rizk.
I was just saying we are going to have a session geared to introduce that paper to patients in the next few weeks, actually. And we will talk about the registry. Because again, this is one active area where we need patients to contribute to it.
Sure. Another question I got privately was, do you have advice for early career researchers in vestibular migraine?
The field is ripe for the taking. I don't think there's any, there's a lot of questions. And, whether from the NIDCD standpoint, which is taking interest in vestibular disorders, or through AMD, which is fostering grants as well, I think there's a lot of avenues to find the resources necessary. And I'll let Monica talk about the AMD portion of it.
Oh, I completely agree. I think we need, again, as a trained basic researcher, I feel there's a need for basic researchers in this field, as well as migraine. I mean, we don't have too many. And I think that's where if you truly want to understand the pathology or pathogenesis of some of these conditions, I mean, we need more basic research. And then we need those collaborations or basic researchers to collaborate also closely with the clinicians to see what are they seeing in clinic and how does that inform them or inform their research. So definitely, I think this area is ripe for research. So again, hope NIH definitely pays some attention to this and helps. And again, through, with AMD, we are, supporting researchers. Again, there are many areas of migraine as well as vestibular migraine. We definitely want to see more interest generated. And again, with Migraine Science Collaborative, definitely want, others to come engage there and interact and collaborate with one another. So lots of areas that we need to be addressed.
Sure. To address your comment, Ms. Nancy Harris-Bonk, you can ask the questions directly in the comment section. Another question that we got from Kelly Amspacher, I'm sorry if I'm butchering your name, could you explain Alice in Wonderland phenomena?
You're talking about the visual symptom. Basically, it's kind of it's one of the migraine manifestations where there's a distorted field of vision. I'm not I'm not very knowledgeable about this specific phenomenon in particular, but it is something that is described by a lot of migraine patients. The same as visual snow. Visual snow is those patients who have those visual distortions. Looks like a parasite in their end of broadcast type screen on their in their field of vision. The best way you can talk about visual snow, you can reproach it to tinnitus, where this noise that is there in the background that is bothersome. But Alice in Wonderland phenomenon is one of the many manifestations of migraine and is related to visual field distortion. So it's not an eye issue, it's a brain issue.
Great. From Dr. Kathleen Strauss, can you comment on the challenge of comorbidity and the challenge of diagnosing vestibular migraine?
As I said previously, it's not uncommon for patients to have many vestibular diagnoses. There's one paper that I can't recall which date it was, in the past 5 years, that estimated about 60 or 70% of patients presenting to a vestibular clinic have more than one diagnosis explaining the range of symptoms. So, which is why it's very important for us not to get, if we find BPPV, it doesn't mean that's the only thing. To be able to get a good history and understand the range of symptoms the other vestibular disorders can produce is also as important. And it's not uncommon for my patients to go out with multiple explanations for their range of symptoms. And understanding that overlap and feeling comfortable with it is the first step forward, which brings us back to the registry, which we need to collect data and understand the range of phenotypes and symptoms that patients with vestibular migraine present with, so that we can educate the clinicians who are interfacing with those patients better.
Sure. Dr. Mallampalli, someone is wondering if you could provide us more detail about why we see a higher incidence of migraine in women as compared to men.
Yes, so there has, we still, again, don't fully understand the pathophysiology, but there is definitely a hormonal connection to migraine that has been well documented. And again, in generally, there is, again, it's well known, it's the women who do present more of those symptoms. And I'm blanking here, Habib. I mean, I think there is, again, there is definitely that hormonal connection to migraine that we see with women.
I agree. I mean, the vast majority of patients are perimenopausal, and the typical vestibular migraine patient, as Monica said earlier, this is a patient who had migraine all her life, then the headaches go away around perimenopause or menopause, and then they present with vestibular migraine type symptoms with headaches in the background. And we don't know more than that at this point.
Sure. Yeah, thank you. Ms. Nancy Harris-Bonk is wondering, Dr. Rizk, if you could go into more detail regarding the difference between Meniere's and vestibular migraine.
So the criteria to diagnose Meniere's disease, you have to have at least 2 episodes of vertigo, which is a sense of an illusion of movement, a sense of displacement in space, associated with at least 1 or more otologic symptom, fullness or pressure in the ear, ringing in the ear, and a fluctuating hearing loss. And to definitively diagnose Meniere's disease, you have to have at least 1 hearing test showing a drop of hearing in the low to mid pitches of sound, which is below 1,000, like 1,000 hertz and below. Whenever you see a hearing loss in that range of pitches, the first diagnosis that comes to mind is Meniere's disease. The other symptoms I just talked about, the fullness in the ear, the ringing in the ear, a sense of loss of hearing, can be described by some of our vestibular migraine patients. Actually, the ICHD, the International Classification of Headache Disorder, in their 3rd edition, when they finally introduced vestibular migraine as a subtype of migraine disorders, they put in the footprint the overlap between Meniere's disease and vestibular migraine is still a little bit misunderstood. There might be cases where patients have both, and we need to understand more about that. But the ICHD recommendation is whenever you have somebody who is diagnosed with Meniere's disease, prioritize the treatment of Meniere's disease, because there's a risk of losing a full sensory organ, which is the hearing portion of the ear. So we need to be proactive in diagnosing and treating Meniere's disease. Again, there's some folks who say that Meniere's disease is only a migraine phenomenon happening at the level of the sensory organ and the inner ear, rather than a separate disorder. This is a very controversial topic from that standpoint. The latest data recognizes, and it's coming out of Europe, 5 phenotypes for Meniere's disease. One phenotype is idiopathic, associated with a mutation in water channel disorders and of the flow of water into and out of the hair cells of the ear. Another one is Meniere's disease associated with autoimmune disorders. A third one is post-traumatic, post-surgery. And there's one subset that is clearly associated with migraine. Any clinician who treats both disorders will tell you there's a high prevalence of migraine in Meniere's disease, but not every single patient with Meniere's disease will have a migraine disorder.
Great. Another question I received was, which care gap would have the highest impact in your view, Dr. Mallampalli and Dr. Rizk, if it were addressed first?
I think it's the registry. That's what we feel. I mean, it's going to take some time before we gather all that data, but definitely, yeah, I think it'll inform us much more.
Dr. Rizk, do you agree?
I agree. I agree with Monica. I think the registry is the most important step going forward, because yes, I mean, there are devising a patient-reported outcome measure is great. Finding an objective measure is important, but we need to understand the range of phenomenon that we want to treat and label under vestibular migraine, and we still don't have a good grasp about that.
There's clearly a lot of work to be done in this area, as in all areas of migraine disorder. So I want to take this time to promote the Association of Migraine Disorders Travel Grant. This program, or this opportunity, reimburses travel expenses for those attending a scientific meeting or symposium related to migraine. This opportunity is open to undergraduate, graduate, or postdoctoral researchers whose program is registered in the United States. I want to highlight that priority will be given to those individuals who are presenting a poster or oral presentation at the meeting to which they're traveling, but this is not a hard prerequisite. In order to apply, you can access the application on our website, www.migrainecollaborative.org. And this is a short application that includes a spot to upload your CV and a letter from your advisor or PI that confirms your good standing in the program, as well as a brief questionnaire. The deadline to apply for this opportunity is April 4th, so it's coming up in about a month, and we hope to receive your application. It looks like that might bring us to the end. Thank you so much, Dr. Rizk and Dr. Mallampalli, for joining me today, and thank you to our audience for asking such insightful questions.
Thank you.
Thank you, Nick. Thank you, Nick.